You know the drill. The doctor says take a deep breath. It's such a simple request, right? But what are they really listening for? Well, today we're pulling back the curtain on the respiratory exam. We're going to decode all the critical, sometimes life-saving clues your breathing can reveal. I mean, you've definitely been there. That cool touch of a stethoscope on your back, the familiar instruction to breathe in, breathe out. But have you ever stopped to wonder what they're actually looking for? What kind of secrets can your breathing possibly spill? Let's dive in and find out. The whole thing really boils down to this four-part sensory investigation. Seriously, you can think of your doctor as a detective using their most basic yet incredibly powerful tools, their own senses. They look, they feel, they tap, and they listen. And each one of these steps uncovers another layer of clues about what's really going on inside your lungs. Okay, so first up, it all starts with the simplest tool in the bag, the eyes. Let's talk about the absolutely crucial visual clues a doctor gathers, long before that stethoscope even makes an appearance. It's pretty incredible how much you can learn just by watching someone breathe. So on the left, you've got all the signs of normal, easy breathing. The chest moves up and down symmetrically, there's no straining, and you can speak in full sentences no problem. But the signs on the right, they tell a very different story. Accessory muscle use. That's when you can actually see the neck and shoulder muscles pulling to help breathe. And retractions, that's when the skin literally sucks in between the ribs. Both are unmistakable signs that the body is struggling for air. And those visual clues can point to some really serious issues. If the chest is moving unequally, that could signal a pneumothorax, a collapsed lung. Using all those extra muscles is a classic sign of what's called respiratory distress. And retractions, that often means there's a blockage somewhere in the airway. And all of this critical information is gathered just from looking. All right, next up, the investigation moves from sight to touch. Let's get into the tactile story. The important clues a doctor can literally feel with their own hands. So when a clinician puts their hands on your back and asks you to take a deep breath, they're feeling for that chest expansion. Their thumbs should move apart nice and evenly. They're also checking for things like tenderness over your sinuses. But one of the most unusual things they might feel is something called crepitus. And yes, you read that right. Crepitus is often described as a Rice Krispies feeling under the skin. It is literally the sensation of air bubbles that have escaped from the lung and are now trapped in the tissue right under the skin, which is definitely not where they're supposed to be. It's a dead giveaway for an air leak. So what's the diagnosis here? Well, if that expansion isn't equal, they might be thinking of a collapsed lung, or maybe a pleural effusion. That's just fluid building up around the lung. Sinus tenderness? Probably a sinus infection. And that crackly Rice Krispies feeling? That points directly to an air leak. Okay, we've looked and we've felt. Now it's time to cap. In this section, we're going to treat the body like a drum to solve what we call the percussion puzzle. Now, this might seem like a really old-fashioned technique, but trust me, it's incredibly informative. A clinician taps on your back right over the lung fields and listens. A healthy, air-filled lung sounds resonant. Think of it as a nice hollow sound, like a well-tuned drum. But if something's off, that sound changes dramatically. It can become either dull or what's called hyperresonant, which means it sounds too hollow. And these different sounds are basically diagnostic clues. A dull thud suggests that the lung isn't full of air anymore, but something dense, like fluid from pneumonia. And on the flip side, a booming, extra hollow sound means there's too much air trapped inside, a classic sign of a collapsed lung or emphysema. And now we arrive at the part everyone recognizes, the stethoscope. It's finally time to listen to the sounds within. So normally, your breathing makes these clear sounds, which doctors call vesicular sounds, and they should be pretty much equal on both sides of your chest. But oh boy, there's a whole vocabulary for the abnormal sounds they might hear. Things like crackles, wheezes, or stridor. Or, and this is probably the most concerning, they might hear very little sound at all. First up, crackles. This sound is often compared to the sound of Velcro being pulled apart, and it means one simple thing. There is fluid down in the smallest airways, the alveoli. This is a huge clue for conditions like pneumonia or congestive heart failure. Next, we've got wheezes. This is that high-pitched, almost musical whistling sound that a lot of people are familiar with. It's caused by air trying to squeeze its way through airways that have gotten too tight or narrow. This is absolutely the hallmark sound of asthma. And then there's stridor. Now, this one is different, and it is extremely serious. It's a harsh, high-pitched noise that's heard when a person breathed in, and it means there's a blockage in the upper airway, the windpipe. This isn't something to wait on. This is an emergency that needs immediate attention. So let's just quickly recap these crucial sounds. You hear crackles, you think fluid. You hear wheezes, you think bronchospasm, like an asthma. If you hear almost nothing, that could be a collapsed lung. And if you hear stridor, that's a critical upper airway obstruction. You see, the stethoscope isn't just listening, it's actively diagnosing. So we've looked, we've felt, we've tapped, and we've listened. What happens now? Well, this is the magic part, where all those little clues come together to form the complete clinical picture. This is really where all comes together. If a doctor sees unequal movement and hears a hyperresonant sound when they tap, they're immediately thinking about a pneumothorax. If they hear a dull thud and crackles with the stethoscope, they're thinking about fluid. It's just a fantastic example of clinical reasoning where each sense adds another crucial piece to the puzzle, often leading to a diagnosis way faster than any high-tech scan ever could. And that really brings us to our final thought. I mean, we live in this incredible age of CT scans and MRIs. So what does the enduring power of these simple, hands-on techniques tell us about the art of medicine? I think it reminds us that at its very core, medicine is about careful observation and human connection. It's about using the most advanced tools we will ever have, our own senses, to decode the stories our bodies are trying to tell us.